Xin phép được giới thiệu các quý vị chủ đề cuối cùng của chúng ta hôm nay là tư vấn di truyền và chẩn trước sinh, Genetic Counseling and Prevention Genetics. Và bài trình bày đầu tiên chúng ta sẽ nghe từ giáo sư Kathleen Ann Leppig với tiêu đề là Update in Prevention Care. Sau đây xin mời giáo sư Leppig trình bày.
Okay, thank you. Okay, good afternoon, everyone. Everybody's still awake. I think they have me talking late in the afternoon because it's actually, I think, 2:30 in the morning in Seattle, and it may be the only way to slow me down from talking really fast, which is a bad habit. I'm Kathleen Leppig. I'm a medical geneticist. I'm also a cytogeneticist. I've done all kinds of genetics from pediatrics to adults to prenatal to cancer genetics. And right now, the focus of our conference has been about the importance of what we can do to help families have healthy babies. I always tell families that having a baby is the greatest leap of faith you have in your lifetime because there's so much you can't control. And when you think about what you can do in terms of prenatal care, this is a way of trying to optimize your chances to have a healthy child. Okay. Oops, and I've already messed it up. I think of prenatal care being built on 3 pillars of information. One is family history, because you want to know if there is anything in a family that you should know about that the pregnancy could be at risk for. So taking a good family history is essential. We're talking about carrier testing of patients, and I just spoke to a lovely doctor here who told me that you are starting to do carrier testing of the mother to see what she is a carrier for. We are all carriers of genetic conditions. What carrier testing is doing is trying to identify some of the conditions that are more common and that we can test a father for and help a family make a decision. And finally, I'm going to talk about testing a pregnancy and our different options to test somebody once they're pregnant for prenatal diagnosis. Okay, I'm going to watch my time. Okay. Oops. Okay. A comprehensive family history should include a 3-generation pedigree. We always ask about ethnic background. We ask if there is any risk of consanguinity, and we're most concerned if there is a relationship between the parents of second cousins or closer. We ask about information about individuals in the family with genetic conditions, birth defects, and intellectual disabilities. We're not as great about asking about adult onset conditions, but we should. And, I think we're just understanding the scope of adult onset conditions like cancer, but that should be part of what a 3-generation family history includes. They take time and they can be complex, but they are essential for rare conditions. Okay, and I'm going to give you an example of a family I saw. Okay, this is the family came to me with a question about what does our son have and what is our recurrence risk for having another child with this condition. So this is a 4.5-year-old male with intellectual and developmental disabilities. MCA refers to multiple congenital anomalies, and this distantly positive family history. He is a second child born of a normal pregnancy, but his medical history was remarkable for post-axial polydactyly He had esotropia, a bifid uvula, a VSD, as well as a PFO, which spontaneously closed. He was nonverbal at 4.5, but ambulatory. And when he came to me, he had a normal chromosome microarray testing, and he had normal FISH for 22q11.2 deletion. Okay, this is my little guy. And if you look at him, he's got some features that are unusual to me. He's got wide set eyes. He's got a somewhat thick bulbous nose. His ears are a little simple and posteriorly rotated. So we went on to do whole exome sequencing, and we got a variant in a gene called ATRX. Now, we've been talking about variants of uncertain significance and how they are our greatest problems in terms of geneticists right now in our life. So here I've got a VUS and a family that's asking me for recurrence risk for subsequent pregnancy. But there's some information that the lab gave us. They said that this variant is not frequently seen in NOMAD, which is one of our databases. In silico analysis supports the missense variant has a deleterious effect on the protein, and this has never been previously published as a pathogenic. So because of that, this is GeneDx, one of our really wonderful laboratories. It was called a variant of uncertain significance. So what do we tell the family? So we go back and get some family history. So ATRX, that gene, is an X-linked condition. And we go back and ask some family history, and there are 2 other individuals in this family that have had significant intellectual disabilities. It's an X-linked condition, so we're going to expect that males are going to be the ones that we're concerned about. And this man had intellectual disability, and he died in his 20s of cancer, and that turns out that he had an osteosarcoma and required his leg to be amputated. And his other, I guess that's a second cousin, also is in his 30s currently and had intellectual disabilities. So we're still working on how can we do this. Just to go over what alpha thalassemia X-linked intellectual disability syndrome is. This is from Gene Reviews. Craniofacial findings include a small head circumference, widely spaced eyes like my little guy has, a short triangular nose, a tented upper lip, and some of the coarsening of features, which is kind of a thickening appearance of features. They have genitourinary anomalies. Alpha thalassemia was observed in 75% of affected individuals. I tested my patient for it. He doesn't have alpha thal. They have mild to profound intellectual disabilities, and interestingly, they have osteosarcomas. So the second cousin, the boy that's still alive, tested positive for this variant. We went back to GeneDx and said, what do you think? And now this variant has been reclassified as being pathogenic. So we can use that for prenatal testing for this family. But this, I summarized this in a couple of slides, but this took a lot of work and a lot of digging and going back to families. But that's sometimes what you need to have an accurate family history, especially if there's intellectual disabilities identified in a family. So the family history is essential. And I'm going to go from family history quickly and jump to carrier screening for genetic conditions. I'm going to talk about 2 groups a lot in this presentation. I'm going to talk about ACOG, which is the American College of Obstetrics and Gynecology. And I'm going to talk about ACMG, which is the American College of Medical Genetics, because I will be referring to their guidelines frequently. Okay, ACOG gives us some pretty important recommendations for carrier screening. Every pregnant woman should receive information about carrier screening. Carrier screening and counseling is ideally performed before the patient is even pregnant. So if you are of reproductive age and you're thinking about a pregnancy, that's when we think we should start your carrier screening protocol. If a woman is found to be a carrier for a specific genetic condition, their partner should be tested to do an appropriate risk assessment. He should be at least tested for that same gene. If both partners are found to be carriers of the same genetic condition, genetic counseling should be offered with consideration of pre-implantation or prenatal diagnosis. Family communication is very important when a genetic risk is identified. And I know that is very difficult in families because some families perceive genetic disease as some type of problem that goes beyond biology. And it's really important to get past that this is anything that's other than a genetic variant, because that's the way that you're able to have open communication. It is important to obtain the family history of the patient, and if possible, her partner as a screening tool for inherited risk. And prenatal carrier screening does not replace newborn screening. That's really important. Carrier screening frequently covers a set number of disease variants, but won't cover every disease variant. So that does not replace newborn screening. ACOG has a recommendation for the panel for carrier screening, which should be offered to any woman who is pregnant in the United States. And the core panel includes spinal muscular atrophy, which we just learned about from Dr. Khan, cystic fibrosis, hemoglobinopathies, and Fragile X. And for individuals who are of Ashkenazi Jewish heritage, Tay-Sachs disease. This is a really bare bones panel. And if you are identified as Ashkenazi Jewish, there is actually a different panel that you could ask for beyond this core panel. But the question is, there is such an admixture in the United States. Some people don't know what their ancestry is and what their risk is. So the question is, should we be going to a panel that is just kind of based on what you think your ethnic background, or should we have a broader panel to be offered to all patients? We have expanded carrier panels with 500 genes or more on some of the panels. And as I said, we are all carriers for genetic conditions. But if we find that you're a carrier for something, we're going to be obligated to testing your partner. So some people say that if we move to these expanded carrier screening panels, we should be testing both parents right at the get-go because we're likely to find something. So that is something that is being worked into considerations. Really interestingly, there's 3 different levels of panels through a company called Invitae. There's a core panel, there's kind of this primary panel with 117 genes on it, and then there's the expanded panel with 500 plus genes. They charge you the same for either level of the panel. It's $200. So the question is, when you tell families that, they're mostly going to say, I want to know more. And we know if we test you for more, we're more likely to figure out that you're a carrier for something. Did I go too far? Oh, so we're going to talk about spinal muscular atrophy again. And this has been an important addition to the carrier screening panel for all the reasons that were pointed out by Dr. Hong in the previous talk. This is a really horrible disease. It occurs, it's been on our panel for carrier screening since 2008. It's a recessive condition. It's estimated that 1 in 6,000 to 1 in 10,000, actually that's a mistake. It's 1 in 6,000 to 1 in 10,000 infants are born worldwide with spinal muscular atrophy. About 2% of the time, these disease variants are de novo. It is thought to be the most frequent cause of infant mortality. And the treatment for it that Dr. Hong pointed out is showing some really important success, is also extraordinarily expensive. The first year is, you told me the other night, it's not 750,000 US dollars, it's $1 million US dollars. And for every year subsequently, it's about 375,000 US dollars. Now, we've already talked about some of this. The genetics of SMA is complex because there's a pseudogene sitting right next to the normal gene. And this is what happens for most individuals. You've got 2 copies of SMN1 and 2 copies of SMN2. The pseudogene you can talk into working some. There are some individuals who are silent carrier that'll be missing a copy of SMN1 on one allele, but will have duplications. These both SMN1 and SMN2 can occur in multiple copies. This is a carrier, kind of the most common configuration of a carrier, and this would be an individual who's born with SMN1, with SMA. So we are trying to screen for this finding. I'm going to show you a slide that you've seen before in Dr. Hong's talk, and it's going to show you the carrier detection by ethnicity, and it's not perfect in any sense. The carrier risk by ethnicity changes a little bit. Individuals who are of Caucasian ancestry are about 1 in 35. It seems to be lower in individuals who are of Hispanic ancestry, but again, we are dealing with more and more admixture of our world's population. If you detect 2 copies of SMN1, you still have a residual risk of being a carrier because of potentially being that silent carrier with the 2 copies of SMN1 on one allele and the deletion on the other allele. And then if you have 3 copies of SMN1, you still have a residual risk because these can cassette on one allele so that you have multiple copies. So we always give you a residual risk. Again, this is the reason why this is prenatal screening, this is carrier screening, this is not diagnostic, and that's important. The American College of Medical Genetics has come out with practice guidelines for carrier screening. All pregnant patients and those considering pregnancy should be offered Tier 3 screening, which is for conditions where their carrier frequencies is greater than 1 in 200. They don't think that the core screening that we talked about with CF, SMA, hemoglobinopathies should be applying because they don't provide equitable evaluation for all ethnic backgrounds. So we've got in the United States, I just wanted to point this out, we've got the American College of Obstetrics and Gynecology with a slightly different opinion than the American College of Medical Genetics. because we're trying to broaden carrier screening because people want to know as much about risk as possible. But then people are concerned if you test a mother and she's positive for a carrier, you're going to create more testing for the other parent. So that's a balance that we're trying to figure out, because more genes, you're more likely to be a carrier. So this is a wonderful paper. This is the ACMG practice guidelines for carrier screening. I would recommend that as a resource for anyone. So we're going to jump from that to screening for fetal abnormalities. So we've talked about screening a family with family history. We've talked about screening a couple with carrier screening. And now we're going to talk about screening a fetus. And these are the three different pillars. So our options for testing fetus were previously invasive procedures such as amniocentesis or chorionic villus sampling. They are costly and time-consuming because they require cell culture. Amniocentesis was performed in the second trimester, and it takes, from the time of amniocentesis, it takes about 2 weeks before you've got enough cells grown in culture that you can harvest them and do a karyotype. And the problem with amniocentesis is that in second trimester, a pregnancy is less private, and women sometimes would rather their pregnancy be private if they're making personal decisions. There became the integrated screen where you evaluate nuchal thickening as well as different blood markers. That was less costly, but it has to be timed right, and there are multiple evaluations needed at different times. And then came cell-free DNA testing. So this is referred to as non-invasive prenatal screening or non-invasive prenatal testing. People have preferred the screening because this is not a diagnostic test. Again, this is a screening test. It's pretty simple to do. It requires a peripheral blood sample from the mother at about 10 weeks gestation or greater. The turnaround time is 10 to 14 days. This was previously, like amniocentesis, only offered to moms of advanced maternal age, where your risk for aneuploidy is highest, so 35 or older. It's now being offered to almost every woman in the United States. It's covered by most US insurance plans. And again, this is screening, not diagnostic. And I want to talk a little bit about what this is. So in your blood, you have your red cells, you have your white cells, you have your platelets, right? But you also have DNA that occurs outside your cells. And this is from breakdown of the own maternal cells, just as you have cells go through death, you have fragments of DNA floating around in your blood. And then you have cells that are dying and being shed by the fetal placenta. And those DNA fragments are in the maternal blood. And so what happens is when you collect a blood sample, you spin it, you get the plasma on top, you get your packed cells on the bottom, and you look at the cell-free DNA in the plasma, and you're comparing the fetal fraction versus the maternal fraction. Okay, now the current recommendations for NIPS, NIPT, the American College of Medical Genetics recommends that this is offered as a first-line fetal aneuploidy screening over traditional methods for trisomy 21, 18, and 13. It's can be used for singleton and twins. If you get multiples over more than twins, it's not recommended as well. You can offer NIPS for fetal sex chromosome aneuploidies, such as Turner syndrome or Klinefelter syndrome. And ACMG also suggests offering NIPS for 22q11 deletion syndrome or DeGeorge syndrome or velocardiofacial syndrome, which is the most common microdeletion syndrome occurring in about 1 in 4,000 individuals. And just to look at a comparison of CVS versus amnio versus the sequential maternal serum screening and NIPS. NIPS is doing actually pretty well. You can see the timing of CVS is about 11 to 13 weeks. You need skill set to be able to do CVS. There's a risk of miscarriage of about 1% of less, but it's less in people that do it repeatedly. There's sensitivity, 99% of all aneuploidies. False positive rate is less than 2%. Failure rates is about 1%. Cost is about $2,000 because you've got to culture the cells. Amnio is done at 16 weeks or greater. Risk of miscarriage is lower than CVS. It's also very sensitive with a low false positive rate and a low failure rate. But again, you've got cell culture that is going to up your prices. Sequential maternal serum screening, again, it's done between 10 and 22 weeks with a combination of ultrasound and serum screening. There's no risk of miscarriage, which is great. Its sensitivity is less. About 90% of cases of Try21 are detected. It's got a higher false positive rate. Its failure rate is very low, but it's cheap. It's relatively cheap compared to the others. NIPS is done early at 10 weeks. There is no risk of miscarriage. Its sensitivity is close to that of CVS and amnio. Its failure rate is very low. Its false positive rate is very low. And this price is coming down. This has been quoted as $800 to $3,000. I know from working in a laboratory that the actual cost of doing this test is probably about $75 US. So hopefully we will see that reflected in the price to patients soon. There are some important considerations about using cell-free DNA technologies. You should always confirm an abnormality detected on cell-free DNA testing by amniocentesis or CVS. Single gene disorders, like finding a specific alteration in the cystic fibrosis genes that you have identified by carrier screening, is not recommended. People are still saying you should do CVS or amnio for that. You should especially not use NIPS or NIPT for any condition that has a repeat expansion, like myotonic dystrophy or Fragile X, especially if mom's got the same condition. You're going to have a lot of confusion with kind of your fetal and maternal fraction. Cell-free DNA testing for pregnancy will expand. There are now panels that include copy number variants, and there's work in process to do whole exome sequencing from cell-free DNA. That's in development. I know the doc who's in Boston who's doing that. One of the big drawbacks of doing whole exome sequencing on cell-free DNA is the amount of blood that you need to take from mom to get an adequate amount of fetal DNA, and that's estimated to be 50 to 100 mLs. So we'll see how that goes in the future. Most moms don't want to give that much blood. The challenges to go over about NIPS and NIPT, you need a fetal fraction of 8% or greater for best results. Your fetal fraction is affected by gestational age and maternal BMI, how heavy your mom is. The heavier your mom is, the poorer your fetal fraction. Triploidy fetuses are harder to detect. They have a lower fetal fraction, and they're missed by methods that are non-SNP. Twins, each twin will have different fetal fractions. There's an increased no-call rate. And if discordant for sex or aneuploidy, there's an increased false negative rate. So if your fetuses are the same sex and the same ploidy, you're much better than if they're different sexes and different ploidies. I want to talk about false positives in NIPS. And there are some important false positives. One is the vanishing twin. 3% of pregnancies are twins, and it's thought to be 5 to 36% of twin pregnancies results in a vanishing twin, a twin that is lost. So you can still, if that twin is lost and is being in the process of being resorbed, that is going to create some cell-free DNA in the maternal system that may compound your interpretation. Maternal chromosome abnormalities, about 8.6 of called sex chromosomal aneuploidies are false positives due to maternal chromosome abnormalities. So these are moms who are mosaic for a 45X population or 47XXX population, or some of the rare mosaicism for autosomes, like trisomy 8. So those are really important that you have to sort out. And the other thing that we have become to realize is that maternal neoplasia has been a big reason for false positives. You get death, you get turnover of cancer cells, and that DNA can end up in the maternal system just like that of the fetal DNA. And as a cytogeneticist who's done a lot of cancer genetics, one of the common things in cancers is that they gain and lose chromosomes. So it's very common in leukemia to have loss of chromosome 7, gain of chromosome 8, and gain of chromosome 21. Gain of chromosome 21 is the most common cytogenetic abnormality in all hematologic neoplasias. It's one of the reasons why children who are born with trisomy 21 or Down syndrome have about a 5% risk of developing ALL, because acute lymphocytic leukemia, because that's present in all their cells when they're born. But gain of chromosome 21 is a common somatic change in both pediatric and adult leukemia. So there was a recent paper given at ACMG that about half of the no calls now in NIPS and NIPT are because of maternal neoplasias. So that's becoming a really important. Can you back up the other slide? So you can see that NIPT, NIPS is doing pretty well in terms of its sensitivity for detecting trisomy 21, trisomy 18, and trisomy 13. I think that we're going to continue to move forward with this technology. I think more and more we're going to see panels that are not only for aneuploidies, but are also for more of the common chromosome deletion duplication syndromes. And I think it's going to be a while, but at some point I think we're going to see whole exome sequencing coming from a cell-free DNA fraction, although I don't know how many moms are going to give 100 mLs of blood at this point. So anyways, the point of this is that this is yet another approach of what everyone's trying to do to ensure healthy babies and healthy pregnancies. This is one part of that story that includes all the other work that we've been talking about. Thank you.